Good morning, students. Mr. Lochan here. Um, this is new to me, so I want you guys to please bear with me. I just want to say hello to all of you, and firstly, hope that all of us are safe and we are comfortable, and our families are also safe at this time. I remain very concerned from a global point of view, but also for our country and all of us collectively. I hope that we are remaining safe and adhering to the guidelines that the government has installed. So, what I'm doing here this morning is really coming on the heels of this uh, shutdown almost with respect to our classes. I know many of you have some questions and you may have some concerns, but this is a beginning, and I hope that we can work together and give you guys the comfort that you require. I just sent some information to you guys on Moodle, and one is a general letter to all of my students. So just giving you an idea of the situation right now from my perspective through the school. But what I want to accomplish this morning for a short while is when I'm looking at your notes, I saw that we had to do some practical related sessions on phlebotomy, smear preparation, and blood typing. So what I've done is I have attached 3 pieces of notes with respect to those sessions, and by tomorrow or so I will send a video of each one of those being done. I also at this time want to encourage you to visit Medical Scientific and Community Support Services Facebook page, and I'm sure you will find some of those things already there and very helpful. And I also want to encourage you guys, because we'll be doing a lot of this from our homes, that we also visit YouTube sites and try to lock into those areas. All right. I know there may be some concerns, and I understand, but I want, on behalf of the school, also to assure you that we will be putting things in place as time progresses to ensure that you as students feel comfortable. All right, so what I want to do this morning is go through a few areas with respect to the notes that I sent on phlebotomy, um, smear preparation, and blood typing. So I will be reading it, and you guys could always leave messages and even use the Moodle and WhatsApp group for us to communicate. All right. I know there's a lot of information being transferred back and forth with respect to the virus affairs. So I'll try my best to sift and sieve through those so that I can attend to your questions as well. All right. So for those of us who may have taken a few minutes to go and get the um, whenever you see this video, I would recommend you go and get your notes as well with respect to what I sent on Moodle today, being the 19th. So for the notes on phlebotomy, your selection of materials such as needle sizes and syringe sizes for venipuncture is based on factors such as the size of the vein, the age of the patient, and the volume of blood required. It is important that phlebotomists or any person performing phlebotomy duties know the volume of blood required for tests in order to collect correct amounts and not have patients inconvenienced by having to return for repeat samples. Alright, that's an important point. In spite of the point listed in number 1 above, one must remember that vacutainer tubes are designed to hold a certain volume of blood, and this carries through whether the tubes are anticoagulated or non-anticoagulated, and also whether the tubes are pediatric, 3 ml, 4 ml, 5 ml, or 7 ml. Regardless of the size, upon manufacture, a specific volume of air is removed. So that means, students, when these tubes are manufactured, a particular volume of air is removed and I'm having my tea, a particular volume of air is removed. That volume will satisfy the amount of blood that is required to be placed in the tube. Regardless of size, upon manufacture, a specific volume of air is removed, and thus the tubes are labeled with a specific tube fill capacity. It must be noted here that even if a tube is called a pediatric tube, it may not always be used for pediatric samples. This is important. The tube may be called a pediatric tube, but rarely it can take blood from a human being, an adult human being. It could even take blood from non-human patients, but the volume of blood will be different. Alright, it will be reduced. In spite of the points listed in number 1 and number 2 above, it is now a good time to discuss another important aspect of successful phlebotomy procedures, which can stand on its own as a major contributor to reduced viability and even rejection of some samples. Even in the presence of a proper blood draw and the use of appropriate tubes, an anticoagulated sample can be affected if the tube was mixed improperly. What I'm saying here is that a phlebotomist or anybody doing phlebotomy duties could actually draw a sample of blood properly. They can use the right syringe size, right needle size, but if the tube is not mixed by gentle inversion 12 to 15 times, the sample will not be as effective as or as viable as you would want. Alright, so if an anticoagulant tube is not inverted gently 8 to 10 or even 12 to 15 times, the sample may not mix too well with the anticoagulant, and thus partially coagulated blood or microclots can be formed. These, of course, are detrimental to tests such as glucose, PT, PTT, and CBCs. One must also bear in mind the following detail as it relates to the form of the anticoagulant found in anticoagulant tubes. Remember, anticoagulant tubes has an anticoagulant in it, and these anticoagulants are designed to suit or to do a particular job or to function in a particular way. That aside, I want to also remind us that they come in different forms, and these different forms are actually the foundation for why some samples come to the laboratory less than optimal. Anticoagulants come in forms such as crystalline, which is found normally in the purple or lavender top, liquid, which is in the blue tops, and fine powder, which is in the gray tops. While there may be some variations, these are the most common forms the preceding anticoagulants come in. Since the anticoagulant in the blue top tube is a liquid, then it is most easily mixed with blood by inversion. So it means blood is a liquid, the anticoagulant is a liquid, so there's no need for it to have any major problems once it is inverted properly. The other thing here is purple top tubes, which contain a crystalline liquid, which contain a crystalline EDTA, require a gentle inversion, and that gentle inversion must be done 12 to 15 times in order to achieve adequate mixing of anticoagulant with blood. Students and trainees are advised to look at the bottom of purple top tubes while inverting gently to assess if the crystalline anticoagulant is dissolving. Even so, the greatest challenge with respect to clotted or partially clotted samples is observed in the gray top tubes. These tubes most oftentimes contain an anticoagulant, sodium fluoride, potassium oxalate, in the form of a very fine powder. This powder, when it comes into contact with blood, can sometimes partially cake up or aggregate, which causes it to more slowly mix with the blood. Failure to adequately mix a sample of blood introduced into a gray top tube can easily result in the sample improperly mixing with the anticoagulant, and therefore glycolysis will not be fully halted. Remember, the purpose of the sodium fluoride in the gray top tube is to stop glycolysis, and if this particular nature of that anticoagulant in the gray top tube is such as a fine powder, and it may not dissolve properly if it is not mixed properly. So with that, it is imperative that all anticoagulant tubes are mixed by gentle inversion, but the one that is most susceptible to improper mixing and therefore the formation of microclots, and even coagulation, which detrimentally affects hemolysis. I'm sorry, glycolysis. You must mix your greater tubes properly. Alright, so glycolysis is a process whereby cells utilize or break down glucose. And this can happen even after the blood is withdrawn from the patient. This is important to know. Glycolysis or the breakdown of glucose can occur outside of the body. Right? There is an approximate 5 to 7% decrease in glucose values per hour if a blood sample is not properly mixed with the anticoagulant in the greater tube. Greater tubes are the most common anticoagulant tubes to be received completely clotted, partially clotted, or hemolyzed. With respect to hemolysis, students, it has been observed that a significant degree of hemolysis occurs in greater tubes where lowered volumes of blood were added. The most common area for venipuncture in most patients is the antecubital fossa. This area has three important veins called the cephalic, the basilic, and the median cubital. These three veins, along with their varied tributary veins, form the main framework for venipuncture procedures. The selection of a vein should include the use of three measures. These measures are the tying of the tourniquet, the clenching of the fist, and the palpating of the site in an effort to locate a vein. Now, a good practice is to ask the patient to outstretch both arms for you as the phlebotomist. In so doing, the phlebotomist can quickly assess a preferred arm where a vein can be readily observed even without the use of a tourniquet or palpating the antecubital fossa. Right? So, what this means, students, is that even before you attempt to utilize the trio of things I just mentioned, you can just ask the patient to outstretch both arms, and by doing so, you can actually see a preferred site even before you actually have the patient clench their fist and even apply the tourniquet. All right. Secondly, even if both arms possess visible veins, it is many times observed that one arm may have a vein or veins which are more pronounced or larger in one arm than the next. Tourniquet tying is a very important part of locating a vein. It should be tied tight enough to restrict venous flow, but not too tight that it restricts arterial flow. Sorry about that. The tourniquet and its use is only for locating a vein and cannot be left on longer for a minute due to increased venous stasis, which can affect some laboratory tests. Some persons question whether a tourniquet must still be used on a patient with clearly visible veins. The answer to this is somewhat subjective, students. In one instance, based on the previous statement that the tourniquet is only used to locate a vein, the answer can be no. In another instance, some phlebotomists still use the tourniquet and insert their needles with tourniquets on. Upon seeing a flashback or recognizing the blood flow as the syringe is pulled, the tourniquet is then removed and blood draw continues. Keeping the tourniquet on while inserting the needle is also believed to make the insertion easier and less painful for the patient. One might even add that the constriction of the band shifts the patient's focus from the actual insertion site to the area where the hand is tied. Tourniquets are not to be left on during the phlebotomy draw. Serum calcium is one test which must not be taken with a tourniquet. Additionally, with respect to tourniquet tying, it must not be done too close to the puncture site, neither too far up above it. Approximately 2 to 3 inches based on the length of the forearm is recommended. Tourniquet tying should be smooth and without jerky movements by the phlebotomist. The phlebotomist's gloves and actual making of the tie should be done sufficiently above the patient's forearm so as to not pull the patient's skin. Many times a tourniquet is being tied and the phlebotomist is actually doing his or her job right here, and with this the skin is pinched or the hair on the patient's arm is pinched, and you want to try and remove and reduce that from happening. So you do by making your tie. You do that by and accomplish that by making your tie above the patient's skin. The rabbit ear flap of the tie tourniquet should also not be very long, as this causes too much pulling in order to remove the band satisfactorily without jerking the arm too much. It is at times like these that needles can come out of puncture sites due to major movements of the patient's antecubital fossa. It has been observed also that the median cubital, because it is centrally located in the forearm, the median cubital meaning this vein here. This is the basilic running underneath, and this is the cephalic, median cubital. It has been observed that the median cubital, because it is centrally located in the forearm, is the least likely to move in great degrees, thereby causing increased potential for needles slipping out. Mid-air pulling off of tourniquets also increases the chances of major movements. What I mean by mid-air removal of tourniquets is the tourniquet is on and the phlebotomist just pulls it this way or pull it that way. What I suggest is you pull, but you keep a backup with a finger. You pull the flap that you want to get. You pull the end that you want to get, but you back up with a finger. So there's no major shaking. Alright? It is recommended while pulling the end of the tourniquet that the phlebotomist use his or her middle or ring finger to back up onto the patient's arm so that there aren't major movements during pulling. This here is some of the key points I wanted to bring to you with respect to phlebotomy. Now I want to briefly touch on smear preparation. For this, and consistent with the notes I sent you earlier on today, you will need microscope glass slides, microcapillary tubes, or any suitable alternative, methylated spirit, cotton balls, and napkins. Now, this audio and video recording is envisaged to kind of be a supplemental preparation for practical with your class in particular. Alright, so of course the foundation and the reason for doing a hematology smear will not really be readily found here. Alright, but nonetheless I'll take a few minutes to just reiterate or just for clarification when a hematology smear is requested. The CBC or complete blood count is, as the name implies, a complete evaluation of a patient's cells. There are 5 white cells. There are the red cells that houses hemoglobin, the oxygen carrying pigment, and of course there are platelets, the smallest circulating fragment of the blood. Through hematopoiesis in the bone marrow, blood is manufactured and they come out into circulation based on timelines designed by normal blood making processes, and also you can get that with um, increased particular needs such as infections that require a certain cell type, or even anemias that require more red blood cells, etc. So bearing that in mind, based on a patient's clinical condition, a doctor may request not only a CBC but a hematology smear or a differential count. In hematology, we would have discussed that, but this here is um, a little few points with respect to the hematology smear. And again, I ask you to visit Medical Scientific's Facebook page so that you can get some knowledge there as well. And it's your own homeboy, so you could feel comfortable to shoot me a message and you know, comment on anything you see. Right. So number one, a hematology smear is essentially a thin preparation of a patient's anticoagulated blood, which is then dried and stained using a special hematology stain. This stain highlights the 5 different white blood cells, red blood cells, and platelets. EDTA, anticoagulated blood, which is in a purple top, is normally used, but freshly drawn non-anticoagulated blood can be used at the point of collection. Whilst blood that is completely free from any foreign material, such as anticoagulants, is ideal sample to use, this is not very practical. As a result, ADTA anticoagulated blood is routinely used to make hematology smears. Hematology smears must be made from freshly drawn samples so as to not have cellular anomalies develop as the cells age. It is preferred that smears be made within 4 hours of sample collection. If this is not possible, then at least same day is satisfactory for best results. Even before a smear is made, some important aspects of the materials used needs attention. Microscope slides must be clean and free from grease. Students, I want to encourage you guys to even make sure and do your good housekeeping, because an improperly cleaned slide or a dirty slide and a dirty spreader can take a good technique that you may have and render it useless in making a smear. So I want to encourage you to take your time, and I'll just take a few minutes to just tell you how these slides are supposed to be cleaned, or how they are cleaned most commonly. To start with, you will be very fortunate if you get a slide that is ready to use and clean out of the box. You don't normally get that due to storage, due to manufacturing imperfections, and thing. You can get the development of microscopic mold, fungi, even dust, and thing. And these things could cause a problem. In addition to that, gross imperfections in the slide, such as chinks in the edges and scratches, could cause major problems. So the first thing you want to do is, from the procurement or acquisition point of view, is to locate slides or use slides or buy slides from good sources that has a good quality slide. Even so, I make it a practice, once a slide is about to be used, I make it a practice to clean my slide with a lint-free cloth, or a napkin or paper towel or so, and just dipped in methylated spirits, and I wipe and I clean one side. With that, that is the side that I'll be attaching my drop of blood to. I also clean my spreader, and that spreader needs to be cleaned, as you would see in the notes here, need to be cleaned and checked for cracks and imperfections, because any minute crack in your spreader will cause you to end up having a smear that is not optimally satisfactory for staining and even doing counts. So hematology smears must be made from freshly drawn samples so as to not to have cellular anomalies develop as the cells age. It is preferred that smears be made within 4 hours of sample collection. If this is not possible, then at least same day is satisfactory for best results. Even before a smear is made, some important aspects of the materials used needs attention. As I said, microscope slides must be clean and free from grease. This will severely affect the quality of the smear. The spreader must also be clean and free from any chips or irregularities on the side used to spread the blood smear. I sometimes gently rub my fingernails on the edge of my spreader to assess if there are any chips or cracks my eyes may have missed. A small drop of blood is required, but the use of the word small here is subjective. Approximately 20 microliters of blood can be used. This can be easily achieved by using microcapillary tubes placed into the purple top tubes almost horizontally. So, if this is the purple top tube, we take a microcapillary tube and we put it inside here. Of course, the tube must be well mixed by gentle inversion. You open the cover and you put your capillary tube in there, and by capillary action and by gravity, blood is going to come into the capillary tube. With that, now you come and you put it onto your microscope slide. Let's assume that this is the slide. You come and you gently tilt, and that drop of blood is going to come. Do not come this way completely, because a big drop will come out. All right, just showing you visually. Utilizing my hands. When I do the actual demonstration, it will make more sense to you as you are seeing it. All right. By capillary action, blood will flow upwards into the tube. At this stage, it is important that the top end remains free and is not accidentally covered with any fingers. Sometimes trainees and students make a mistake in that they accidentally cover the top of that capillary tube, which means that air or anything cannot move. So you will not get blood to flow and you will not get it to leave the capillary tube. Alright? It is slowly raised towards a vertical position until a small bead is formed at the tip. This bead is then gently touched onto the slide, which causes it to affix onto the slide. A clean spreader is then placed onto the glass slide sufficiently in front of the drop of blood. Right? An angle of approximately 30 degrees is maintained. So I'll just quickly draw that here for you guys. This is the drop of blood, and then you bring another slide, and you bring it towards the drop. When the spreader reaches the drop of blood, and if the spreader is clean, the drop will smoothly, evenly, and relatively quickly spread along the edges of the spreader. When this occurs, the spreader is stabilized and pushed along the slide with a straight, fast tendency. The resultant smear should have a smooth feathered edge without scratches or irregularities. The smear is left to air dry and then subsequently stained. Sometimes dipping the smear into methanol helps with better fixing the smear onto the slide as well as achieving better clarity in staining. Alright, this is what we are seeing in the bottom of that note. You would see a smear that was made plus the smear that was stained and ready for examination under the microscope. Alright, so with that, I also want to just give me a few seconds here. I'll just locate my blood group. Right. With respect to blood groups as mentioned are inherited surface antigens on red cells. As a result, the basic immunological reaction with blood groups will involve looking for those antigens, and in order for us to identify those antigens, we expose them to antibodies. So there are antibodies to A, what is called anti-A, antibodies to B, which is called anti-B, and antibodies to D, or the rhesus factor. Blood groups can be done usually by two methods, tube method or slide method. No matter which method you use, blood from the patient must be exposed to reagents or antibodies to A, antibodies to B, and antibodies to D. So if you're using the slide method, you would need microscope slides that are clean, or there's a special blood grouping slide that has concavities where there are little depressions on the slide, and your reagents are added to it with your blood cells. If you're using the tube method, one drop of blood is added to tube A, B, and D, where A is for blood group A, B is for blood group B, and D is for the rhesus. One drop of anti-A is added to your first tube, one drop of anti-B is added to your second tube, and one drop of anti-D is added to your third tube. These three tubes are gently picked up. This is the traditional method. These three tubes are picked up and they are looked at by examining for clumping or coagulation, and you're not shaking it up in a rough way. You are gently turning your tubes, alright, where coagulation or agglutination is indicative of that particular blood type. Alright, so I hope that this little video was in good clarity and in order for you guys, and I am available for any queries, any questions coming out of this session. So please keep well, and I will be updating stuff for next class as well, so that you will get an idea Alright, as I look at your class schedules, as I look at your particular class schedule, Saturday people, I'm seeing that, and I want you guys to help me. I'm seeing that we did microbiology, urinalysis, hematology. We started immunology. I want to know if we finished immunology. All right, so you guys can tell me if you finished immunology, and we are here now. All right, looking at your data also, I saw that we had a proposed finish date of the 21st, I'm sorry, the 9th of May. So just be utilizing this opportunity to just regroup, and I will be paying some close attention to your timeline and look out for updates on Moodle. Alright students, keep well and take care.